thank you very much for joining us today. Off to a very clean start there. Thank you for joining us in another year of Cornerstones for the best of ACR 2021. For those of you who don't know me, I'm David Liu, and I'm joined today by two colleagues, Andrew Oster and Rebecca Granger, who will introduce properly in a moment. Thank you to them both for being here. Thank you to you all for signing in, and many of you will have been familiar with the Cornerstones format, but Rebecca will talk us through that in a moment. But before we do that, I'd just like to acknowledge country. I'd like to acknowledge the Wurundjeri people, and who are the traditional custodians of the land of which I'm on. I'd like to pay respect to the elders past, present and emerging of the Kulin Nation, and extend that respect to other Indigenous Australians present, and to the First Nations people of the land that you're on as well. So thank you very much. And Rebecca, I will pass over to you to explain what Cornerstones is.
Thank you. Tēnā koutou, tēnā koutou, tēnā koutou katoa. This program, Cornerstones, is supported by an independent educational grant from Janssen. Thank you very much. Next slide, David. So you're just about to launch into 1 hour to 90 minutes of the best of ACR Convergence 2021. And I know this because we worked very hard to make sure we're bringing you the best. We'll introduce the faculty in a moment, but let me tell you about the process. First of all, we get rheumatologists and an advanced trainee from New Zealand and Australia, hand-picked team. As soon as the abstracts come out, we review all the abstracts and we meet on Zoom and discuss looking for abstracts which gain our interest, but ones that we also think will have some clinical relevance to you in your day-to-day practice. We review over 80 abstracts during the virtual convergence sessions, and then we narrow down to the ones we think will have the most impact on practice in New Zealand and Australia. We put together the slides, including the key findings. In some of the slides, you'll see we've grouped several abstracts with overlapping or complementary information in together. After ACR, we have a number of Zoom meetings where we discuss each slide and ensure the content is truly representative and select very, very carefully the best material for you to digest tonight. Sometimes we contact the original authors or look at their work in more detail. And we present to you tonight a comprehensive slide deck, a bespoke slide deck for New Zealand and Australian audiences that you can probably use in the clinic today, tomorrow, or next week. Next slide, David.
Sorry, yes, apologies. There we go.
So I'll just take a moment to acknowledge and introduce our faculty. I'm Rebecca Granger. I'm a rheumatologist based in Wellington, where I do public hospital clinical practice and have an academic role at University of Otago. We've got Dr. Erwin Lim, who's a private practice rheumatologist based in Sydney. Associate Professor Helen Keane, a rheumatologist in clinical practice and academic medicine over there in Perth. And then my two wonderful colleagues with me tonight, well known to many of you, I'm sure. Dr. David Liu, rheumatologist and clinical pharmacologist based in Melbourne and working at Austin Health, and Associate Professor Andrew Oster. Andrew, you've got a lot of letters after your name.
I worked hard on that. I worked very hard on that. Harder than Cornerstone.
Harder than Cornerstones. More letters after your name than in your name. Consultant rheumatologist at Cabrini Medical Centre in Melbourne and a principal investigator at Emeritus Research. And the faculty were delighted to have with us Dr. Pallavi Shamdasamy, who's a registrar based at RMH in Melbourne. And she was really helpful reviewing the abstracts and putting the slides together. We're very grateful for her help. So what a treat we have for you over the next 2 nights. We've split this so that you can engage fully with what we present tonight and then have a bit of a break and come back for more tomorrow. So tonight you're going to hear the hot abstracts on rheumatoid arthritis, spondyloarthritis and the oral surveillance data. If you care to join us tomorrow, lupus, vasculitis, dare I say it, COVID-19, and other, which doesn't sound very exciting, but I can tell you that it's those little tidbits that really bring that little bit of extra information you've just been looking for. So I think we are ready to launch into part 1, and I will hand over to Dr. Liu and Associate Professor Oster. Take it away.
Thank you. Thank you very much, Professor Granger. It is, I think it's been great to be able to work with the same group again. We've kind of, we've got it down to, I don't want to say a fine art, but we certainly have figured out how to go through the conference in a way which works for us, try and capture everything that we can and try and bring you the best of what we've got. So I want to talk to you a little bit about the rheumatoid arthritis slides to start with. And some of the abstracts which we think are going to have the biggest impact on your practice. So we want to start at the very beginning and talking about early rheumatoid arthritis. And I think early rheumatoid arthritis has always been full of disappointment, Andrew, wouldn't you say? I think that in ACR, we've always seen studies which have looked like they should do something, but then we haven't really been able to do anything to try and prevent rheumatoid arthritis from coming along. Particularly thinking about those high-risk patients, patients who we know are autoantibody positive, who are ACPA positive, who may have had some sustained arthralgias already, have imaging findings on MRI scan. But how do we stop those patients, and with their very real joint pain, from progressing through to full-blown rheumatoid arthritis with clinical synovitis? Well, I think this is a question that's been bothering us for a long time. We've got no therapies. We've not proven that methotrexate as an intervention or TNF inhibitors as an intervention have been able to manage this situation to prevent the development of early rheumatoid arthritis. What about abatacept? With the knowledge that maybe co-stimulation is a reasonable target to try and prevent citrullination, in the context of citrullination, to think about preventing clinical synovitis that prove for autoimmunity. So what this study looked at, this is a multi-center study across 14 centers, 11 of them in Germany, and it looked to do an intervention which could be reasonably applicable to our practice. 6 months of abatacept, and only 6 months. And then after that, following up and seeing what happened and whether that short, sharp intervention, relatively short, sharp intervention, was enough to prevent the development of early rheumatoid arthritis. So across these centers, it took them quite a long time to recruit, and I think that speaks to the difficulty of doing this kind of study properly. These are patients who are ACPA positive, MRI findings, inflammatory MRI findings on MRI of the dominant hand, arthralgias greater than 6 weeks, over the age of 18. Looking at that in a double-blinded randomized controlled trial way, what happens? Well, abatacept in that we're going to see 6-month data here in terms of ITT, and that's what you can see on the table here. Abatacept outperforms placebo. Now, you might imagine that that's in many ways treating early rheumatoid arthritis. Some people might argue that this is rheumatoid arthritis in everything but definition. And we can see that in terms of preventing improvement on MRI and preventing progression to synovitis, there's a substantial benefit to abatacept over placebo. What was really tempting was that in the concluding comments, they mentioned that they'd actually just analysed the 18-month data. So that's 12 months after that first 6-month intervention, and that we saw sustained benefit after that. Now, we didn't see any data from that. We'll see that in the paper, no doubt, in the future. But I guess that's a tempting idea, Andrew, isn't it? This idea that we might just be able to intervene and then stop the relentless progression of rheumatoid arthritis.
It's really fabulous, and we've made such spectacular advances, particularly in rheumatoid arthritis over the last couple of decades. You know, those old historic photos of the deformed, functionless hands has really disappeared. But now we've pushed the boundaries, and this study really looks like a niche for abatacept, and it's a drug that's been looking for a home for a long time. It's a good drug. It hasn't really found its mark, but maybe this is it. And the ability to hit it hard early, switch off the process, and then come off therapy and remain in remission or never develop RAs is really tantalizing. One of the difficulties you said, David, is capturing these patients. We did a similar study when I was in Cambridge, and it was just seeing these people was the hardest thing actually. Australian GPs very often request antibodies, so we have that information, and so I think that this is something that could potentially creep its way in, although funding will be an issue going forward, of course.
But I mean, it's a potentially a tempting idea, and you know, let's say it costs. The intervention might cost, say, $5,000 or $6,000, just hypothetically. I mean, the idea that you might be able to invest early to prevent a lifetime of rheumatoid arthritis, that's very speculative, but the idea is there, isn't it? That we might
Absolutely.
be able to do something one-off. Yeah. I know we'll see much more in this space, and we are really talking about a fairly select group of patients who develop, who are ACPA positive and are getting those MRI findings at that stage. So that still leaves a big burden, you know, as good as we are at managing rheumatoid arthritis, and I think as we talk about it, we'll talk about ways in which we could be better, but as good as we are, we're not good at preventing it. We're not good at curing rheumatoid arthritis. In fact, we're quite bad at that.
Agree.
Well, one of the, yeah. Well, I mean, speaking of which, and I think, you know, we always hear from the Leeds group about, you know, those high-risk ACPA-positive patients and what MRI findings might mean there. I know you and I have talked about this in the past, Andrew, but and then when we think about early rheumatoid arthritis, we think about Leiden as well, and some of the great work that comes out of there. That's what we're looking at here, data from Leiden, and really what MRI findings, in terms of that imaging in that early rheumatoid arthritis stage, what should we be paying attention to and what shouldn't we be? Now, I don't know if it's just me, but often I get referred these patients where they come with an MRI, and the MRI, I might have even access to the original image. The MRI is potentially of dubious quality, but there are findings on there. It's hard to know exactly what means what and what would mean a progression to rheumatoid arthritis if the patient didn't already have rheumatoid arthritis. What is this looking at here? Well, these are patients with undifferentiated arthritis, so they've got some synovitis, but they haven't had that persistent synovitis that would meet rheumatoid arthritis criteria. And often these patients can fluctuate and just dissipate, or may never actually give you that sustained synovitis of rheumatoid arthritis. How can we tell which ones are going to and which ones aren't? This has always been a point of discussion, and tenosynovitis has always been, there's always been a big question about whether that might be a real indicator. Other studies have shown this. These 1,234 consecutive patients from the early arthritis cohort in Leiden all had MRIs, and they looked at erosions, bone marrow edema, synovitis, and tenosynovitis. And following these over the next year, about 1/5 of them progressed from this undifferentiated arthritis through to full-blown rheumatoid arthritis. And apart from ACPA positivity, it's really the tenosynovitis on an MRI scan that predicts the patients who are going to progress. What do you think of this, Andrew? I mean, this is, I guess, you know, once again, we're starting to get a better picture of what are some of these early features in undifferentiated arthritis and the clinically suspect arthralgias even mean.
Well, I saw a patient just 2 days ago who fit this bill, who came in with an MRI with tenosynovitis and synovitis. And from this study, I thought, okay, well, we really need to hit this as hard as we can early in order to prevent progression or any further inflammatory disease. So, look, I think we're getting more refined. This may not be that practical for people who can't get MRIs quickly, but I certainly can. And I think we take note of the tenosynovitis and we look for the synovitis, but there are these features now which give us a steer. I think certainly, you know, if you have that ability to do MRI, it can be very helpful.
Yeah, I mean, being able to stratify in this situation to determine what's important and what's not, I think is of real value, because MRIs which report some minor synovitis or some minor bone marrow edema seem to cause, understandably cause this enormous amount of anxiety for our patients when they don't necessarily have rheumatoid arthritis, and we're not necessarily piling in with the treat to target therapy that we might do if they did have full-blown rheumatoid arthritis.
Precisely.
Yeah. Well, let's keep on talking then. On from early rheumatoid arthritis to the kind of things that we might use to treat early rheumatoid arthritis. Steroids, our old friend steroids, you know, we can't live with them, we can't live without them. And we all know about the long-term risks from steroids. I always, in my mind, steroids cause metabolic syndrome, they're atherogenic, they cause all those problems which lead to cardiovascular risk in the future. And that's how you get from steroid use to major adverse cardiovascular events like heart attacks and strokes. Well, these data from the VA in the US, the VA system, really challenge that. I think this is an interesting idea. What about the short-term risk? If we give steroids now, a short burst of steroids, say a month or two, does that actually create a cardiovascular risk? So in this study, they looked at all rheumatoid arthritis patients that were seen at least once in the VA, but without having a previous major adverse cardiovascular event. So these are patients that, for all intents and purposes, don't have any overt cardiovascular disease, but are in that age group, 40 to 90, and are rheumatoid arthritis patients. We know the risk that's associated with them. So that's 26,000 patients. And they broke down their course into 6-month periods and then looked at corticosteroid prescriptions, looking for over 30 days of use, and tried to match that up with major adverse cardiovascular events in the next 6 months. So that's what we're seeing in this diagram in the top right-hand corner here. So steroid use in a 6-month period, and then adverse events, cardiovascular events in the next 6-month period. And they looked at it, of course, with some very sensible pharmacoepidemiological approaches, not just looking at the unadjusted approach, but also trying to adjust for cardiovascular risk using a cardiovascular risk which has been validated in the VA cohort, which is called VARS CVD, which uses the data they've got there, and then a full model which also adjusted for factors which would be surrogates for rheumatoid arthritis disease activity. So the kind of things which we have come to, over time, to realize are contributors to cardiovascular risk in these patients. So looking at this, what we can see is that there's actually a short-term risk associated with over 30 days of steroids. Over 30 days of prednisolone use in a 6-month period is associated with a 14% increased risk of cardiovascular, the major adverse cardiovascular event in the next 6-month period. And so we can see that in the unadjusted. We can see that when you adjust for cardiovascular risk, and you can see that once you adjust for rheumatoid arthritis disease activity. Now, I don't know if we can necessarily ascertain causality from this. Really, the fact is that plausibly there's an inflammatory substrate which is driving both the cardiovascular event and driving rheumatoid arthritis disease activity, or something else that requires corticosteroids. But certainly this is a challenging idea. Short-term steroids, maybe not so benign as far as cardiovascular risk is concerned. What do you think, Andrew?
Well, we still use a huge amount of steroids. I throw it around like lolly water, I must say. You know, as you said, David, the best drug we have, the worst drug we have. But we're finding out more and more about the risks, and even in the low doses and bone health and here cardiovascular risk. So, you know, it would be nice to think that we could get to a world in rheumatology without steroids. I don't think that's possible at the moment. That initial beautiful rapid response that people get, we really don't have a substitute for that at the moment. But I guess we just keep striving to get the lowest dose for the shortest amount of time possible. And this would certainly support using that approach.
I mean, isn't it amazing that we still go to the Hench lecture at ACR, and 70 years later, this is still the drug that we use the most?
There we are.
Yeah, here we are.
So the audience are listening in intently, but no questions yet. But I'm going to jump in here. It's an increased risk. So these were not high risk people. They had not had a prior event. But do you think there could be a situation where we talk about the baseline risk and the increase in risk? Is this something where we end up with sort of stratified approach to use of prednisone? What do you say to that? Because we're going to cross some data later on that suggests probably risk stratification may direct our treatment with other agents. Do you think that's something we need to consider, their baseline risk of cardiovascular disease? You know, the male smoker in his 50s with a strong family history, the metabolic syndrome, poorly controlled hypertension. You know, is this the patient we say, well, I can give you some steroids, but there's a risk here? What do you think, team?
Well, I know that we're going to talk about this plenty today. And so, I mean, I appreciate the leading question, but I think this is something we're already used to doing, right? I mean, I think that to some extent, we've thought about anti-inflammatories, and maybe we'll return to this theme later on. We think about cardiovascular stratification already in a number of different ways. Now, you say this, and I sit here at my desk with my cup of tea and the sherry that Rebecca suggested that I bring to the table, which I will enjoy later. But when you're in the clinic room and you've got a patient in front of you who's in pain and needs treatment at that point in time, and you know that there's only one drug that's going to bring any form of relief in a modicum of promptness, then I think it's really hard, isn't it? We're going to hear this again.
Yes.
I mean, we can make these abstract discussions about therapies and risks and stratification, but then you've got a patient in front of you who's got real needs and is looking to you for support.
Well, I don't want to put you off your game too much, so I'll duck out again and let you get on with the next slide. Back to you.
Oh, you can jump in any time, Rebecca. I think we've got a lot to discuss about stratification. I think it's a really important point. Let's talk a bit about stratification and liver function tests. And I think part of this is about challenging things which exist there and trying to find the data to answer the questions which might sit at the back of our minds in clinic for a lot of patients. What about methotrexate? And I've always had this niggling thought at the back of my mind that I know that liver function tests aren't good at picking up fibrosis, at hepatic fibrosis. Yet that's what I use to try and determine whether methotrexate is a problem in terms of hepatic fibrosis in my patients. I'm not routinely fibroscanning these patients. I'm certainly not routinely liver biopsying these patients, no matter how long they've been treated with methotrexate. Now, I know our dermatology colleagues over time, and it's a slightly different population, but they've previously set down guidelines, firstly at 1.5 to 2 grams lifetime cumulative methotrexate dose, and then subsequently at 3.5 to 4 grams cumulative dose over a lifetime. That even if you had normal liver function tests, you should get a liver biopsy at that point. A not particularly pleasant procedure, not without morbidity associated with it. Is this something that's valid? Now, we live in an era now where fibroscans are more readily available, and so for these to try and understand this relationship, we can actually use FibroScan to see whether there's actually any validity in this at all. So what is this? This is a cross-sectional observational study from British Columbia in Canada. In a single rheumatology, in a single tertiary centre, they offered all patients on methotrexate a FibroScan, and they looked to see how that related to cumulative methotrexate dose and then other factors that might contribute to hepatic fibrosis. What did we see? Well, look at the scatter plot here and look at that trend line in the broken red line. I think that helps answer the question. Now, in amongst all the screening that goes on in amongst this, and whatever we're doing at the moment with liver function tests to screen out the patients who might potentially be at high risk, it didn't really matter. Once you're still on methotrexate, there's no hidden hepatic fibrosis that's brewing underneath the surface. No correlation between cumulative methotrexate dosage over a lifetime and a FibroScan score. What if we were to break it down by segments here, and I guess thinking of those recommendations in mind, and you can't, once again, less than 500 milligrams, 500, 3,000, 3,000, 6,000, over 6,000, we're not seeing any difference in FibroScan. Of course, we're filtering out the patients with abnormal liver function tests, but that's enough, it seems, that our current approaches actually are fine, that we don't need to necessarily panic. What does predict hepatic fibrosis? Well, that's where I think it comes down to. I think it comes to this idea that this is really about non-alcoholic fatty liver disease. And we saw in this, in the multivariable logistic regression, that BMI and age were the things that predicted hepatic stiffness on FibroScan. alcohol consumption, in fact, didn't. Maybe that relates to the way that we stratify and screen on our heads. But it's the metabolic features, which are really the things that we need to be working on. Did this kind of challenge your thinking, Andrew? Or did this just tell us what we were doing all along was right?
Yeah, look, we were never as worried, I don't think, as the dermatologist, and the initial use of methotrexate in psoriasis, different conditions, different doses, and so it really was a different landscape, but we were stuck with that legacy. And, you know, I never quite believed that the cumulative dose was going to be an issue, and this is really supportive of that people can continue treatment in the long term on methotrexate and not run into troubles, and we need to look at the entire patient and their metabolic syndrome, their cardiovascular health. So, look, you know, it's as much as I love and hate methotrexate, you know, it does have certainly has a role, and I think we can use it safely in the longer term.
Absolutely. All right. So on the flip side, going from methotrexate to other kind of newer small molecule drugs, and I mean, Andrew, we joke about this all the time, but whenever this study comes up, we need to say this, don't we?
Greatest trial study title ever.
The Jackpot Study. So what is a Jackpot Study? In case you haven't encountered it before, it's an essay cohort looking across 14 national registries across Europe. Now, they're quite diverse, and we've seen data at previous ULRs and ACRs about the differences between the countries. So let's put that proviso on it. This is real-world data from a variety of different systems. But what is it? It's capturing JAK inhibitor use, and in particular here we're interested in what happens once you fail a JAK inhibitor, either through ineffectiveness or because of an adverse event. Do you go to a JAK inhibitor or do you go to a biologic? Well, let's first look at the global survival. There's Kaplan-Meier here in the bottom left-hand corner. Looking at that, and in terms of patients still on therapy, the orange line's going from a JAK inhibitor to a JAK inhibitor, and the blue line, the aqua line's going from JAK inhibitor to a biologic DMARD. And you can see that in amongst, and there's probably some channeling in amongst this, the performance is very similar. I think that gives us some reassurance, really, that in terms of effectiveness, going from a JAK, once you have to strike out on a JAK inhibitor, going to another JAK inhibitor, going to a biologic, probably doesn't make a whole load of difference. Let's drill on that. If you stopped a JAK inhibitor because it was ineffective, and does it make a difference whether you go to another JAK inhibitor or a biologic? And, you know, there's kind of reasons why that might be plausible, that you might go to a biologic or might go to JAK inhibitor. And really what you don't see in this is any difference between that. So if you stopped on inefficacy, you go to a JAK inhibitor, and JAK inhibitor, so what you see here is that it doesn't really matter whether you choose one or the other. You're going to get the same type of response either way. What about if you stop on the basis of an adverse event? What happens after that? Does it make a difference if you go to a JAK inhibitor next or a biologic next? And this is what we're seeing in the column graph in the bottom right-hand corner. If you go from a JAK inhibitor to a JAK inhibitor, you're likely to strike out on the next JAK inhibitor on the basis of another adverse event. So adverse events beget adverse events as far as going from a JAK inhibitor to a JAK inhibitor is concerned. But going to a biologic DMARD, we don't see that. So I think that ultimately, what does this say? And with all the provisos of real-world data, that basically, once you fail a JAK inhibitor, doesn't really matter in terms of effectiveness whether you go to a JAK inhibitor or a biologic. But if you've failed on the basis of an adverse event, then you've really got to look to a biologic therapy to try and avoid that adverse event. Did this surprise you, Andrew, or is this kind of in keeping with what you would have expected?
Well, we've been using loads of JAK inhibitors, haven't we? We're highest uptake in the world in Australia. And, you know, many people don't want injections, and so we have been switching between JAKs. And I think this is reflective that you can obtain a response by switching between JAKs. They're not all the same, different pharmacokinetics, dynamics, and so, you know, we really have that opportunity. And I think that is interesting. If you're going to stop one for an adverse event, it may be that it's time to look to an alternative mechanism of action. But I must say, overall, the reason for stopping JAKs is more in efficacy than adverse events. They tend to be pretty well tolerated. So I think, you know, there's certainly an opportunity to switch between JAKs before moving to parenteral treatment.
Great. Well, that takes us to the end of our rheumatoid arthritis slides, just on time, and that's the point where, unless Professor Granger has any further questions for us.
No, there's no questions in the panel. I was just, as you're talking, you'll be aware, I think we've chatted about it, that we recently got funding for Vitilisimab for the indication of rheumatoid arthritis. I'm not getting a good track record. So far I've had 2 patients back who have both failed due to adverse events. So I'm gunning for some differences in the next patients that come back.
Keep going, Rebecca. 2 berries don't make a tsunami or a whatever. Just keep going.
Yeah. Well, yeah.
New Zealand will be catching up.
All right. So I can't change to another JAK, so I'm begging for some tocilizumab. So thanks very much for rheumatoid. We'll move you on to spondyloarthropathy now.
Thanks for that entree, Dave. We'll hit the main course now. Spondyloarthritis. Thank you. Next slide, please. So, you know, we've been really blessed in psoriatic arthritis. The number of therapeutics, advanced therapeutics, increasing, catching up to rheumatoid arthritis was the poorer cousin. Now, really a lot coming along and on the horizon. And now we have the most recent addition, guselkumab, available to us for psoriatic arthritis. You know, it's a bad day when you say the dermatologists have been more advanced than we have, but they certainly have been and been using guselkumab Tremfya for psoriasis with very effective use for in psoriasis. And here now we have the longer-term data of the Discover-2 study from the biologic-naive PSA patients. They got guselkumab, a favorable dosing profile, essentially a week 0, 4, and then 8 weekly after that. And here's the 2-year data. So we've seen the benefits, we've seen the radiographic improvements as well. And actually this is now increased out to 2 years. And we need to know that a drug works and it continues to work for the lifetime of the individual, really. You see the figure there, the ACR 20 responses, and the ACR 50 and 70s parallel that, as well as all the PROs and other outcomes you're very used to seeing in big phase 3 studies. This was then, as I mentioned, the longer term data, and again, the benefits clinically, radiographically, but also, you know, the benefits in the side effect profile. That's why the dermatologists like it so much. You don't have to worry about side effects. And really, this is very close with blockade of, and I should have mentioned this at the beginning, this is an anti-IL-23 P19 agent, that the safety profile of these medications is favorable and really at the low end of what we expect of advanced therapies and not too different to placebo. You see the same rates of serious infections with placebo there. So this is really an excellent addition to our therapeutic armory against psoriatic arthritis. And what are the great advantages here? Well, probably the benefits with the skin, which are extremely good, and the safety with a similar efficacy at the joints level. So, you know, I've been starting to use this a fair bit now, increasing use in the clinic. It's available now, and I think we're going to see a real rise in the use of anti-IL-23 P19s. What do you think, David?
Oh, well, I mean, I think a bit of early success always gives you a bit of courage, and I've had that with guselkumab, so I think that always plays into it. Those are the biases that we bring from the clinic to acknowledging those cognitive biases. But I think it's nice to see that as time goes on, we're actually getting drugs which are useful in different ways to us. And we're talking about drugs which in psoriatic arthritis, which are better at skin, which are improving the safety profile, as much as I think TNF inhibitors continue to bring us a lot of good things. being able to see us expect, and it's never terrible to have options. It's always nice to have options, isn't it? So I think it's great. I mean, I think you know as much as anyone, and I think we just to show that we're not biased. We've obviously excluded your plenary from this. We've gone for what we think are the bits
the important things. The important things.
It's an excellent plenary. It was an excellent plenary. I think to see these data, I think are reassuring. I guess we'll we've got another guselkumab slide to come. So shall I flick through to that?
Let's go. So this is a study, the next one that we're looking at, that David was very keen to include in the pack. And I think it is really important because we've been used to treating axial spondyloarthritis with ankylosing spondylitis, and then this different classification now of non-radiographic axial SPA, which appear in many instances to be separate conditions. And then what about the inflammatory back disease that occurs with psoriatic arthritis? Is that a separate condition again? So we're really becoming more refined with our characterization. But here we were looking at guselkumab, again, the anti-IL-23p19 subunit blocker, in axial-related endpoints in PSA, and the results out to 2 years. So we're not seeing benefits with IL-12/23, IL-23 blockade in relation to ankylosing spondylitis. It's not successful in the big clinical trials. But what about the inflammatory back pain in psoriatic arthritis? Well, here we have a post hoc analysis granted from the Discover studies, again, guselkumab in psoriatic arthritis. We see the benefits out to 2 years. I've just shown that data. But what about in patients who have axial symptoms and sacroiliitis, either on X-ray or MRI, and looking at these clinical outcomes, BASDAI, spinal pain scores, and ASDAS through to week 100? Well, actually, this drug has an effect on inflammatory back pain in psoriatic arthritis. So, and that's really regardless of whether it's HLA-B27 positive or negative, we've seen an improvement. So to me, it's saying we're getting better at characterizing disease. If a patient does happen to have inflammatory back disease associated with their psoriatic arthritis, that they may well gain benefit from treatment with guselkumab. We've talked about the safety benefits as well as the skin benefits. So, really, not all inflammatory back disease is the same. And I think now we're becoming a little bit more sophisticated in our approach to this.
I mean, I think part of the reason why I was keen to see this, because it's a very contentious area. I think one of the relevant critiques of this study is the fact that the sacroiliitis was only investigator confirmed, wasn't centrally read. I know there's a lot of debate about that in the AxSpA world. In amongst that as well, I think that there's been a lot of elegant science that's come through, and I know that especially in this country, we've heard a lot from Dennis McGonigal and from Jonathan Sherlock about some really beautiful translational work, which has kind of given us a better sense as to how different domains of spondyloarthritis might actually reflect different cytokine profiles. But having said that, we see these benefits. I mean, they're real there. And I think that we all know as well from in clinical practice that there's those patients that we go about treating the joint disease, and actually they come back and say that their back does feel better as well.
Well, it's only a bonus, and of course there's a lot of back pain out there. But look, here we're getting a handle on maybe helping these patients with these subsets of disease, really.
Yeah, absolutely. Shall I click on, Andrew?
Let's go.
Go.
So you're enjoying your red wine there, and Rebecca, I know, is going to get stuck into the sherry, as you say, a little bit later on. So I better keep her while she's still concentrating and doing a great job here. So here's upadacitinib in ankylosing spondylitis. It's the only oral agent we have available for ankylosing spondylitis at this stage, and here are the 2-year results. So we know the safety and efficacy. We've seen that in the clinical trials in the Select Axis 1 study, and now here's the data again after 2 years. We need drugs that work quickly. You can see that in the figures, and that continue to work over time. And there were the number of outcome measures that are used in ankylosing spondylitis. And also the placebo group actually catches up pretty quickly once you start therapy with upadacitinib. And here they're also, looking at the radiographic MRI changes as well. We haven't seen a major problem with inflammatory bowel disease flares. In fact, it's being trialed in inflammatory bowel disease. Uveitis is from a background you'd expect in this group. So really, the JAK1 inhibitor, upadacitinib, is tolerated very, very well in ankylosing spondylitis, maybe reflecting the demographic of the group. So it works. We're using it now. We're using it with increasing frequency, and there's been no specific new safety issues, but I'm sure we're going to delve into that very carefully in the oral surveillance study coming up. But I think this is really beneficial now for our patients who would like to take oral therapies.
Mm.
Now, I've been using... go ahead, David.
No, I was saying, talking of other therapies and mixing it up, this is, I think I'm really glad you selected this, because this is really interesting for me.
Well, I know we're told not to, we shouldn't use combination therapy, and we've had studies that show that there's lack of efficacy with lack of improvement in efficacy, but increase in intolerability. But I have certainly been used in combination therapy in a number of patients, and this is really to optimize their care. The patient who has very bad disease, but with the joints, but the skin is controlled, and vice versa. The skin is bad, but the joints are controlled. How do you deal with these people with advanced therapies? So I was really pleased to come across this study from our gastroenterology colleagues looking at Vitilisimab, which is an integrin antibody that is gut specific. It has no effect on the joints, but it's good for inflammatory bowel disease. And they're used in combination with biologic therapies in inflammatory bowel disease. You can see they used a number of different biologics in combination. One of the benefits of Vedo is its safety. It's got a very good safety profile. Again, why gastroenterologists like it, they don't have to worry about safety. So not a huge number of patients, 16 patients, and they only had a small proportion of people who were evaluated by a rheumatologist, but the dual biologics were used for inflammatory bowel disease in 75% and for joint pain in 25%. We can see that around 14 out of the 16 remained on combo at the end of the study, and there were infections that were seen. Serious infections requiring hospitalization, IV antibiotics occurred in 2 patients. No cancers, recurrent cancers, no deaths. You can see that the combination there is predominantly with adalimumab, but also with ustekinumab, certolizumab. I'm really reassured by this data. I think when you have somebody who has bad inflammatory bowel disease and they're treated with Vedo, they're doing okay, but their joints are bad, that we have an opportunity to actually combine therapy. And look, we do this and it flies well under the radar, particularly with I have one dermatologist, my go-to dermatologist. I prescribe a biologic for the joints. He prescribes biologic for the skin, and the patient is on 2 biologics that is completely transparent and allowed by the current system. So I think we shouldn't be too worried about combination, but we obviously need to monitor these people very carefully.
Well, Associate Professor Oster, I'm just going to jump in right here because I'm going to be a little bit more guarded.
I'm worried. I'm worried.
Well,
Rebecca.
I'm just going to point out there's 16 patients with a mean age of under 40. You haven't had a lot of time by the time you're 40 to accumulate a lot of comorbidities, and we know that comorbidities are a very big driver for risk of infection. Additionally, I would note that the follow-up was for a mean of 12 months. Now, probably the first 6 months are of the biggest concern, so we've captured that highest risk time, but 12.5% with serious infections with hospitalisation or IV antibiotics, that's not trivial. So I agree, when your back's against the wall and you've got a young patient with really inflammatory disease and big impact on their life, you know, we can sometimes take steps that are outside day-to-day practice, but we do need to balance that up against the risks. So I'll temper your enthusiasm slightly, but I also admire the strength of your underpants.
Thank you, Rebecca. We need the balance here, don't we? Need to bring me back to the regression to the mean here. Look, we don't do it very often, and it's all about, as you mentioned, risk stratification and looking at the right patients who may be able to tolerate this and be treated appropriately. 12%, but there were 2 patients. Maybe there was something specific about those 2 patients, and we need bigger numbers, of course. But I think one of the benefits of, say, for example, the IL-23 blockers or 12/23 is that they have a very good safety record. So those are the ones that I'm looking more with combination here with biologic or JAKs. I don't know what the audience is now. I'd be very interested to hear their experience. But really, when you have somebody who is in real strife, then what's the fallback is more steroids in a way. And we've seen what the problem are with steroids. So you've either got a biologic or you give them more steroids. So I think we're gonna have to make that decision, on an individual basis.
So can I challenge you? The audience is with me, I'm afraid, Andrew. We've had a comment that I agree with Granger and a warning of the ice being rather thin. And I'm not sure, maybe this is a comment that the other speakers will understand better than me. Danger, Will Robinson. I'm not sure I understand that, but perhaps it means something to you, Professor Oster.
You missed all those cartoons as a kid, Rebecca Granger, because that's Robbie the Robot who used to say, danger, danger, aliens approaching. So we do have to be careful, but I would say, and I like to think that I coined this term, but it almost certainly wasn't, but familiarity breeds complacency. We're very familiar with steroids. We just throw them around. We're seeing the difficulties, the problems increasing with steroids. So to my mind, it's really almost safer to use, if not safer to use another combination therapy than just to pile in more steroids with all the long-term problems. But I agree, we do need to be careful in this space.
Although the Vitilisimab sounds like a less risky combination than some of the others, but you know, right. Thanks for bringing. It's good to have these debates and see the different range of practice. So thank you very much.
Well, can I just maybe even challenge the idea first about these combinations? That I think we're attuned to thinking that combination biologics are a bad idea from anakinra data, and Vitilisimab is not anakinra. And we're looking at a very different situation. But Rebecca's disappeared from the screen, so I can't challenge her on that. But I don't know. I think that there's clearly patients where, yeah, she's back. Well, what do you think about that? Because I mean, I wonder whether we're set in our ways from the date, trying to, thinking about one biologic at a time, partially on the basis of cost, partially on the basis of those early data, which skewed us away from that. But I guess the other thing I would say is that in other therapeutic areas outside of rheumatology, we do see combination monoclonal antibodies. We've seen bispecific monoclonal antibodies start to emerge as well. That's kind of on the spectrum to where we're going here. So, I mean, yeah.
I mean, what I'd love to see is a future where we're selecting the biologic that we know is appropriate for this patient now, and that combinations are driven by the particular inflammatory profile of that patient. Now, Andrew, you're indicating that you and your dermatologist sort of do that by the clinical phenotype, but actually I'm looking forward to a future where we profile these patients' inflammatory state and choose the particular combination of drugs which treats their particular inflammatory condition. Rheumatoid arthritis, it's an endpoint phenotype, and when we do this very rudimentary algorithmic kind of approach. So that will be the kind of combination where we have actual patient level data for that patient driving our choices, and you'd be much more inclined to accept some risk if you knew you had this bespoke cocktail of medicines that were designed for you. So that, you know, it's on the future, but there's things around now that I didn't think, you know, that were on the future when I was a young rheumatologist. So anyway, with that, let's move on.
Okay, all right. Before we get into, you know, talking about personalized medicine, RNA-seq and all the rest of it, but we should talk about the abstracts, which are really, I think this group of abstracts are what dominated this meeting. And really in amongst us, we want to kind of give you some idea in a short period of time as to what the key data are from oral surveillance. So we've got 3 slides here, and I've got 13 points in front of me, which I just want to quickly list to open up to discussion to my 2 learned colleagues here. So oral surveillance. What is it? It was of course a phase 3b4 FDA mandated post-marketing requirement study. This is because in the original tofacitinib registration data, we saw numerically increased numbers of cardiovascular events and malignancy. So at that time, part of the registration was doing this PMR study, which has been recruiting since 2014. It's an incredibly expensive and lengthy thing to roll out. And what we saw in amongst it was that in January of this year, we saw the press release, which showed us some high-level data, which led to some concern. Firstly, what are the arms? TOFA 5 twice daily, TOFA 10 twice daily, which in 2019, on the basis of the VTE signal, switched to TOFA 5 twice daily. And then TNF inhibitors, which were different in different parts of the world. So in North America, it was adalimumab, in the rest of the world, it was etanercept. The inclusion criteria are important. So this is obviously moderate to severe RA. These are patients who are enriched for cardiovascular risk. So patients who are over the age of 50, they need at least 1 cardiovascular risk factor, although that could be as mild as hypertension or family history of cardiovascular disease. And this was in combination with methotrexate. Importantly, as well, these patients had no malignancy history, which is of course important for the malignancy data that we're going to see. So these are patients with some enrichment of risk, not you know, the highest of high risk, but certainly there is risk there. The data that we saw before the meeting is what we see here in the middle, and that is looking at the overall numbers for major adverse cardiovascular events and non-melanoma skin cancer malignancies, so solid organ and melanoma. And what did we see? Well, we saw that there was all TOFA versus TNF inhibitors. We saw a hazard ratio of 1.33, which wasn't statistically significant on the 95% confidence intervals, but by the FDA requirements that it had to be this is a non-inferiority study. So the top confidence interval is meant to, the top end of the confidence intervals is meant to be below 1.80. It's 1.94 in this situation. So this is not non-inferior on cardiovascular events. More concerningly, well, as concerningly, was the malignancy risk here. So all tofacitinib versus TNF inhibitors, we saw a hazard ratio of 1.48, which was statistically significant on the 95% confidence intervals. The bit, of course, we'll highlight is that the number needed to harm. So in terms of patient years, needed 412 patient years of TOFA to get over TNF inhibitors to get a major adverse cardiovascular event, and 275 to get 1 malignancy. So that's 41 patients treated for 10 years in order to get 1 extra major adverse cardiovascular event, 27.5 to get 1 extra malignancy. Does this, what about, I mean, the first thing that we should establish of this, is there a difference in terms of how well these drugs work? The answer is no. And what we're seeing here is SDI over time, and you can see TOFA 5, TOFA 10, and TNF inhibitors all essentially overlapping. Very hard to separate them. So looking at the actual data itself, this slide will look at cardiovascular risk and venous thromboembolism. The next one will look at malignancy risk and infection risk. Major adverse cardiovascular events. So we're talking really apart from death, cardiac death, myocardial infarctions, and stroke as well. What happens when we divide it up? Let's look at the stroke data first, which is down here. And you can see here that as far as stroke is concerned, we're not seeing a signal at all. The green is TOFA 5, the blue is TOFA 10 versus TNF inhibitors, and we're not seeing a signal there. Where we are seeing a signal is in myocardial infarction. And we can see that particularly when it draws out when you look at non-fatal myocardial infarction, TOFA5 has had a hazard ratio of 2.32, which is statistically significant by conventional 95% confidence intervals. Does this reflect in real-world data, or is this just a quirk of the study? Well, there are correlating data which we'll look at in amongst this. Pharmacoepidemiological data from the Brigham Pharmacoepidemiology team, and what they've looked at 3 large insurance databases, and that's over 125,000 patients, and they looked at, these are all rheumatoid arthritis patients, and they looked at all comers, without any cardiovascular risk criteria, and that gave you a hazard ratio of 1.01, so not affected. But then when you look at the patients who do have the same entry criteria as oral surveillance, or as close as possible, then you're getting a hazard ratio of 1.27, which, while not classically statistically significant, certainly is heading in the wrong direction. Okay, so what about VTE, since we've got this on the slide as well? Well, I think this challenges us the other way. Well, I've avoided in the past using TOFA5 in patients with a known history of VTE, especially after the TOFA10 data was released showing an increased signal for VTE. So that's TOFA10 in the middle in the blue. But even if you've got a history of venous thromboembolism, comparing TOFA5 versus TNF inhibitors, we don't actually see a difference in terms of VTE risk. If overall, if you have a history of VTE, if you don't have a history of VTE. So that certainly challenged my thinking. I'll keep on talking until someone challenges me here, but we'll talk about malignancy and infection risk. Well, so looking here at malignancy, well, we know that there's an overall malignancy risk. We know, just let's address the skin cancer issue as well. There's certainly a signal with skin cancer for TOFA versus TNF inhibitors. But let's look at the other cancers, so solid organ malignancy, as well as melanoma. And so what they did is they looked at multivariable logistic regression, you take the highest independent risk factors, and then try and accentuate it out on that risk. This is something that we saw for cardiovascular risk as well as for malignancy, that really there's an element of effect modification. That is to say, if you don't have some of those existing risks, you don't necessarily see an increased hazard ratio. But it's when you start to accumulate those risks, age over 65, previous smoker, in this case, for malignancy, then you actually see, that's when you start to see the signal really accentuate. The other risk factor, interestingly, was regionality in terms of the world. So whether you were from the US or from the rest of the world. And while the US certainly had quite a strong signal, the rest of the world, we saw actually all TOFA versus the TNF inhibitors in the rest of the world, and keeping in mind there's a difference in TNF inhibitors, adalimumab versus etanercept, we didn't see well, the hazard ratio was 1.25 and it wasn't significant. Does that mean, I think, well, I'll point out that that TOFA, the point estimates of the incidence versus in the US versus the rest of the world were markedly different as well. And maybe that speaks to the kind of patients that are getting recruited in the US versus in the rest of the world. There's more to be seen in that. I don't think we've heard the end of that story. What kind of cancers were we seeing? Well, lung cancer came out, and also lymphoma. We only saw one lymphoma in the TNF inhibitor group, but we saw many, many more in the TOFA groups. So I think that was a little surprising. Not sure what to make of that. How does the STAR-A pharmacoepidemiology data reflect in that real-world data that we were talking about before from the Brigham? Well, over those 125,000 patients, we saw the same thing once again. You take all comers, you don't see the risk. You take the patients who would make it into oral surveillance, and that's when you start to see the signal coming out there. Lung cancer, once again, was there in the signal. So I think we're starting to see that maybe while it's hard to pull this out from the real world data, the same kind of signals exist. But they really do exist in the kind of, not necessarily all the patients who walk in the door, but the patients who would make it into oral surveillance. Finally, infection. What does it mean? Well, we know that herpes zoster is an issue with JAK inhibitors. And there's a hazard ratio of 3.28 there. But what about when you exclude that and look at other infections? Well, surprisingly, perhaps for me at least, it was surprising, we saw a signal for both TOFA5 and TOFA10 over TNF inhibitors in terms of increased risk of infection. Keeping in mind they have the same efficacy we've seen here. increased risk of infection with TOFA 5 and 10. And that applied for all non-zoster infections as well as serious infections there as well. So I'm going to read out my 13 points for consideration, and then I'm going to throw it to my two learned colleagues, because I know they've got some thoughts on this. Some things I've heard, I've tried to write them down comprehensively without necessarily fear of favour or judgment. But these are kind of reasons, excuses, understanding through the lens, perhaps, of what these data might mean. Firstly, these are rheumatoid arthritis patients. They're not spondyloarthritis patients. And in fact, we saw some spondyloarthritis data at this meeting, which was actually less concerning. What does that mean? Who knows? Baseline cardiovascular risk as inclusion. These aren't all comers, as we've seen. In fact, all comers, perhaps that signal doesn't exist. But once you start to enrich the risk, then you start to see some concern. What about the stratification? And we'll talk about that. But maybe tofacitinib is an effect modifier in this situation. But we're starting to see those patients with existing risk get more and more risk. The statistical analysis we've talked a little bit about, and the magnitude. This is, we're talking quite a large number needed harm in terms of patient years. But having said that, these are versus TNF inhibitors, where we do see the same type of efficacy. Now, there's a bit of debate as to whether this was about JAK inhibitors being bad, or maybe it's just that TNF inhibitors are actually extra good, not in a dissimilar way to what we saw with allopurinol versus febuxostat. And I think that's a relevant question, especially once we start to think about drugs which are targeted agents but aren't TNF inhibitors and aren't JAK inhibitors, so the non-TNF inhibitor biologic DMARDs. There's all sorts of questions about that, and I think it becomes a bit more of an ethical question about our patients and with existing cardiovascular risk. Should this have been extrapolated to all JAK inhibitors? This is TOFA data. Does it apply to barrier UPA? We know what the FDA said, and we can talk about that in a bit. The US versus the rest of the world, then this is once again about yield over TNF inhibitors. Are there sufficient benefits from JAK inhibitors to justify taking on this risk in certain patients? And then what are the clinical implications? So what about the patients who are already doing really well on JAK inhibitors? Would we try and switch those if they've got cardiovascular risk? What about, does this affect decisions like the FDA label have said about first-line agents, choosing TNF inhibitors over JAK inhibitors? Does it affect second-line agents? And will patients care? What kind of caution do we need in the counselling? And then it's really about the follow-up time and whether we've had enough time. Will we see a stronger signal over the course of time? Will we not see that signal? There's a lot of questions still to come. We've got to work through our cognitive biases and all of this. I think we've all got thoughts about it, but I'm interested to hear what Andrew and Rebecca have to say about this.
Rebecca, what do you think?
Well, we've got a question or a question from the floor, and it's really what do these data change? So Dr. Kumar has mentioned in the chat that they had a patient today with nodular rheumatoid who's responded well to a JAK inhibitor but has developed a clot, and the guidelines say stop the JAK inhibitor. Do the guidelines need to change? How should we approach this patient in the light of these data you've presented tonight? I mean, my first question is about other reversible risk factors for the clot. Was there something else we can attribute this to? Do we have to blame the drug? And we do know that rheumatoid in itself is a risk factor for venous thromboembolism. So those are two things to acknowledge, and we might want to just reflect on the pre-treatment risk of the patient. Are they obese or sedentary or venous stasis? Just some thoughts. I'll pass it over to you two for your thoughts or comments.
Well, I think that everything you said is reflected in the data, and that we can see that the VTE risk in amongst this really there are other perhaps bigger factors than the drug that contribute to VTE risk, and we can't pretend to just close our eyes to that. Having said that, I don't think that these data necessarily answer the question about what happens if you develop thromboembolism on a JAK inhibitor. These are patients with pre-existing VTEs, and whether you can give them a JAK inhibitor or not. So I think that there's potentially different mechanisms in play, and so I'd be very cautious about extrapolating these data to that situation. But it does bring up a really interesting discussion. I'm interested what the two of you think.
I mean, I think this is a more tricky one if you've developed a clot on the drug. And I guess it also depends on what they've previously been treated with. If we now have alternatives, we have quite a few alternatives for rheumatoid arthritis. And I think you could probably then just decide to switch to something else. And from the data that we've seen, the Jackpot, you can maybe expect a good response from something else. I think, as Rebecca said, you check everything else. What was the reason for it? Was it a provoked attack? If it was spontaneous, I think you have to be a little bit more cautious. And in this case, I would probably think about changing, unless, of course, you've already tried all the other stuff and that's all you've got. And then I would be happy on anticoagulation. We have quite a number of people now on anticoagulation who continue on JAK inhibitors because that's the drug that suited them the best.
Yep.
What about you, Rebecca?
Well, good points there. I think, Andrew, it's important to acknowledge that the treatment of the ongoing treatment for the previous clot, or treatment that continues with the intention of preventing future clots, is an option. And with the newer direct anticoagulant agents, that becomes rather easier than the bad old warfarin days. So much better safety profile and more acceptable to patients because of the absence of monitoring. So that becomes a more tenable option. But it just reminds me again what an art we practice. The science of medicine versus the art, and that these are often case by case, shared decision making, weighing up the risks and benefits with the patient, and their priorities and values really coming to the fore in guiding the decision making process. I mean, none of us are going to do something that's frankly dangerous, but we will support the patient making choices that might be different to ours based on their values and preferences.
Yeah, look, I've had a couple of clots, but in actual fact, one guy has been worked up for a patent foramen ovale, and it's pretty much, they're convinced that it's put down to that, and they're doing an operation to close it. Another one was said to have had a stroke and end up being a migraine. So I think we've got to also characterize what we're dealing with as well in these situations.
And I mean, I think about the week before these data were presented in detail, and having a conversation with a patient who I had on Barry, been doing brilliantly on Barry, and he needed PCI on Barry, new PCI on Barry. And so in the light of these data, I said to him, well, I think you've got a few, you should know about this. It's not the same drug, but it's certainly a very similar drug. There's potential risks there. This could be contributing to your cardiovascular disease. And he just looked back at me with these stone cold eyes and just said, next question, doc. And I think that's going to be a lot of our patients, right? I think as much as we can talk about risk and whatnot, there's going to be a lot of patient preference involved. I don't know how this affects how we counsel our patients. I don't know, Rebecca, Andrew, if that's changed the way you...
It just reminds me of the Cushingoid patient staring back at you saying, don't you dare reduce my prednisone. So it's the same thing, they've voted with their feet, they've made a decision about their least worst state, and we're not very good at appraising risks that occur to some distant future self. So it's right to keep having the conversations, but we need to realise that we're not always going to land where we think we will.
So I think one of the comments I'd like to make is this is a FDA study. FDA are a conservative bunch, and they err on the side of caution. So they lumped them all together with all the JAKs. I don't think that's appropriate to do. The EMA haven't done that. The TGA, and well, now that you're getting a JAK in New Zealand, we can see what the authorities say as well, Rebecca, but they've decided this is not appropriate to lump them all together. So it's a unique population of a particular drug in a rheumatoid arthritis group. I I don't understand the malignancy. I don't really, that seems, you know, have to be pretty carcinogenic to get you to that stage that quickly after such a short period of time. And we haven't seen that in the observational data in any of the JAK inhibitors. We haven't seen in the longer term observational data. Yeah, I'm not quite understanding that data specifically. But it also highlights that we have embraced cardiovascular health as part of what we do in rheumatology. And as David mentioned, maybe anti-TNF is particularly beneficial in this situation, and JAKs aren't as good. We don't know that, but that could be an interpretation of some of the data. But we just got to embrace the cardiovascular health. And you know, now I'm checking, you know, is your blood pressure being monitored? Have we checked your cholesterol? You know, are we looking at those, you know, pre-diabetes, diabetes aspects? I know tomorrow night we'll be seeing the risks of cardiovascular disease with lupus and rheumatoid arthritis. I think Rebecca will be presenting that. So coming up on Cornerstones. If you tune in tomorrow, you know, we do have to embrace the cardiovascular health of the individual.
All right. Well, thank you very much